Thank you all for joining today. We hope for a robust webinar with all of you. I'll introduce myself in the meantime. My name is Mena Scavina, and I'm a neurologist here at Nemours Children's Health in Wilmington, Delaware, and part of the Certified Duchenne Care Center team. I also work with PPMD as a clinic care team advisor. I know there are many topics that people would like to discuss, and we've seen some of the questions come in. We hope to have additional webinars going forward. So today, I think we'll talk more so about genetics and the interest we all have in the cardiac aspect of carriers. Next slide, please. So I thought I would start with this slide. If you build it, they will come. We all know the movie Field of Dreams, but all of us here really felt that if we had such a clinic, this would very much help women who are looking for the right place to go for their care. Next slide, please. So why build such a clinic? Well, we really want to provide comprehensive cardiac care to women known to be carriers, and in doing so, break down the barriers. Not having providers that know much about their disease or the family history or about Duchenne or Becker muscular dystrophy, and also a place that can expand into other areas, whether it be mental health, wellness, pulmonary, OBGYN. So we're hoping to break down a number of those barriers. We also want to learn more about the heart in carriers. We were recently at a conference on the heart in boys and young men with Duchenne and Becker muscular dystrophy, and we are learning more, and we want to keep women in that conversation so we know what the best tests are and how best to treat them. So that's very much a goal of this clinic. We also want to make sure that as we move through this, we establish standards of care and guidelines. As many of you know, we don't have those guidelines, and we would like to establish those so that clinics across the country and even globally can utilize them to care for women. Next slide, please. So, timing is everything. And as we were working through all this, it seemed as though the timing was just right in a number of ways. In terms of the genetics, Ann Martin, a genetic counselor from PPMD, is here today to discuss with us the explosion, if you will, that there may be in the identification of women as carriers. And so it seemed that more than ever, such a clinic was important so that they would have a place to go for guidance. What we know about the heart in carriers has also increased. Groundbreaking research by Dr. Mei-Ling Ma, who's with us here today from Nationwide Children's Hospital, will discuss her research and that of her colleagues at Nationwide that really looked closely at the heart in carriers and is allowing us to move forward with what we do. And then having the right team to work with. And so today, we have Doctors Teresa Wang and Nosheen Reza from the Inherited Cardiovascular Disease Program at Penn Medicine at the University of Pennsylvania here in Philadelphia. And we were very fortunate enough to meet them, and they took hold of this idea of addressing this unmet need and moving forward with this clinic. So I welcome everyone here, our speakers, and all of you in the audience. We will move from Ann Martin, Dr. Mei-Ling Ma, Dr. Wang, and Dr. Reza, and then we'll take questions at the end. So thank you very much for joining us today.
All right. So like Mena said, my name's Ann Martin. I'm a genetic counselor at PPMD and thrilled to speak with all of you today. I'm just going to give a brief introduction into genetics and genetic testing for carriers. And then I'm really going to turn it over to the cardiologist because I think that's what everyone really wants to hear about today. So just to review, what does it mean to be a carrier of Duchenne or Becker? So a carrier is a person who carries a genetic variant or a gene change in any of their genes that could be passed on to their children. And actually, all of us are carriers of gene changes or genetic variants that could lead to disease in our children. We just don't often know it. And historically, the term carrier has been used because usually in the past, we thought literally that women were just carrying the gene, but didn't necessarily show signs like a male would with Duchenne. But we now know that's not entirely the case, but the term carrier is still used. Um, but I just wanted to kind of explain where that came from. So, a female carrier of Duchenne or Becker carries a variant or gene change in their DMD gene, which is on one of their X chromosomes. Oops, I'm not advancing here. Ah, there it is. It was hidden. Thank you, Amanda. Um, before I go any further, just wanted to kind of go over some basic genetics in case there's anyone kind of new to this area and not exactly sure what we mean when we talk about the X chromosome. I think it's important to understand for the inheritance. So, this picture on the left is showing chromosomes. We have millions of cells in our body, and inside the center or nucleus of each cell are all of the chromosomes, which house all of our genetic material. And if we could unravel that, we would see the DNA strand. And each little segment of DNA is a gene that codes for a protein in our body. So in the case of Duchenne, it's the DMD gene, which produces the dystrophin protein. So as I said, that DMD gene is on the X chromosome. And if you look at the picture to the right, it's showing all of the chromosomes in one human cell. So they're all lined up in what we call a karyotype. And there's 23 pairs or 46 total. And the pair we're interested in is actually that 23rd pair or the sex chromosome pair down at the bottom right. And females have two X's, whereas males just have one X and a Y. So as females, if we have a genetic variant or gene change in our DMD gene on one X chromosome, that typically means we're going to be much more mildly affected or not at all because we have that second X as a backup. But men having just one X chromosome and then a much smaller Y chromosome, whatever they inherit on that X is going to be expressed. So that's typically why, boys or men have more classic Duchenne, whereas women tend to be more mildly affected. All right, so the inheritance of Duchenne, it does follow the X-linked inheritance, like I mentioned. You've probably heard in the past the term X-linked recessive. We're kind of moving away from that because saying X-linked recessive implies that carriers really don't have any signs of Duchenne. And we know that's not the case anymore. So we typically just say X-linked inheritance. And this is showing kind of the chances of a carrier mother having children with Duchenne. So with each pregnancy that's conceived, there'd be a 1 in 4 chance to have an affected son and a 1 in 4 chance to have a carrier daughter. Or you can think of it as each pregnancy that's conceived, if it's a boy, there's a 50% chance he would be affected with Duchenne. If it's a girl, there's a 50% chance that she would be a carrier. So I realize there may be some people listening. I imagine most people listening today are carriers. But if you're new into the Duchenne space or you recently had a boy diagnosed with Duchenne, you may not know yet if you're a carrier, and you may be wondering what the chances are that you are a carrier. So if you don't have any family history of Duchenne and you have a boy who's newly diagnosed, your chance of being a carrier is 2 out of 3, or around 70%. So that means there's a 1/3 chance or around a 30% chance that you are not a carrier. And that's because some of the gene changes that cause Duchenne happen new in the first child affected in the family. So, and this is why it's really important to have genetic testing done so you can know for sure whether or not you are a carrier. So why is it so important to know if you're a carrier? I'm sure many of you know this, but of course, I think one of the more overlooked reasons would be for your own health. And that's really what's going to be emphasized today by the cardiologists who are speaking. Being a carrier can cause increased risk of heart disease, cardiomyopathy, and there are some carrier females who can have muscle symptoms such as muscle weakness, cramping, fatigue. So it's really important to focus on your own health and get the care and support that you need. The second reason would be for family planning. If you're planning or you would like to have more children, it's important to know what the chances are of passing on the Duchenne gene. But it's also really important to know what your options are. There's a lot of options available now for prenatal testing as well as pre-implantation genetic testing. So that could be a whole other talk, and I'm not going to go into details about that today, but just know there are a lot of options and we're available to answer questions at any time. And then, of course, the third reason that you should have your carrier testing done is for the sake of your relatives, because if you're a carrier, then other women in your family could be carriers as well, including your mother, your sisters, aunts, cousins. So it goes on and on. So the good news is we recognized at PPMD several years ago that there really was a gap in women being able to actually access carrier testing because many insurance companies were not wanting to cover carrier testing for women. So we actually added carrier testing to our free genetic testing program, which is called Decode Duchenne. And I do want to just thank our 4 industry sponsors who make this program possible. That's Sarepta, PTC, Vertex, and NS Pharma. So the criteria for carrier testing through our program, it's really quite simple. You just need to be a female with a family history of Duchenne or Becker. You must live in the US or Canada, and you do need a local healthcare provider to submit an application on your behalf. It's actually a very simple one-page application on our website. And once we get that, then we will send your provider the paperwork necessary for testing. So the test requisition and informed consent, and then we can send a kit as well. And actually, most of our carrier testing is now done on saliva swab kits, which is much, much easier than blood. So just trying to make it as convenient as possible. And all of our testing is performed at our partner lab, which is PerkinElmer Genomics. And we're happy to report that we've now had over 650 women who've had free testing through our Decode Duchenne program. So 2 other methods of women finding out that they're carriers that I just wanted to bring to everyone's attention. They're both more general population screening methods, which is unusual. I think in the past, most women found out they were a carrier because they either had a son affected or somebody else in the family was diagnosed. But there's now this general population screening that's picking up a lot of women without any family history. The first I wanted to mention is expanded carrier screening. Sometimes this is called universal carrier screening, and this is offered to all pregnant women or women considering pregnancy, usually at their OBGYN office or family practice office. And they're typically offered a panel, a carrier panel that can include hundreds of genes, but DMD, or the Duchenne gene, is typically in that panel. So we've really, at PPMD, we've noticed a huge increase in the number of women contacting us who find out that they're a carrier and they have no family history of Duchenne or Becker. So I just wanted to highlight that this is kind of the new era of medicine here. And the other type of population screening that's starting is newborn screening. And this is not yet approved in the United States, but there have been 3 different pilot programs going on. PPMD funded a large pilot in New York State that actually finished recruitment last fall. But there's another one in Boston and one in North Carolina. And all those programs are screening all babies, so male and female babies. And they do that by, testing the blood spot from the heel prick, and they are looking at CK levels. So some carrier females will be identified through newborn screening if they have an elevated CK. So I just want to point this out. This is another, type of population screening that's really going to increase the number of women who are finding out that they're carriers. And whether a female is picked up at birth or a male, that's then going to lead to cascade testing of other relatives in the family. Um, so again, this newborn screening is not happening in all states in the US yet, but we're actually in the process of nominating Duchenne to the RUSP, which is the recommended universal screening panel. So our goal is to get newborn screening added to the RUSP, for all states in the US. So I just want to throw in one quick slide about the registry. I work closely with the Duchenne Registry, which is PPMD's self-report registry for Duchenne and Becker, but it's also for carrier females, and we really need carrier data. We really want your data. So if you're listening and you're a carrier and you're not in the registry, we really encourage you to join. It's a simple process. You can start at DuchenneRegistry.org, and we have an app platform that's pretty easy to use. So if you have any questions about anything I've gone over very quickly, whether it's the Decode Duchenne, the genetic testing program, or our registry, or any other questions related to genetics, you can reach out to myself and my colleagues. I work with two other genetic counselors, Nikki Armstrong and Kayla Quirin. So we're all available at the email and phone number on the screen there. And so with that, I am going to turn it over to Dr. Mei-Ling Ma, because I think everyone is excited to hear her presentation.
So thank you. I appreciate the introduction and the genetic background because I think that does dovetail well into a conversation about carrier cardiomyopathy. It's really foundational. I've been seeing carriers now for about 5 years. I think that over time, my perspective on this has evolved. I was really trying to come up with the title for the talk, and it was harder than you might imagine. I do think that in large part, this is about recognition. And it's hard because I think that that is really kind of a starting point. While you would always like to be further along in things, I think we start with recognition and then kind of with that, we can make progress. And so I'm really excited to do this and to um, hopefully contribute to the things that they're doing at UPenn. So I don't have any disclosures. I want to start with the clinical presentation. I understand that there are patients, but also other providers on. And so I'm trying to kind of balance the two. And so hopefully some of this will speak to some of the clinicians on the call and others to the patients that are on the call. So a 50-year-old woman presents to a clinic with complaints of progressive shortness of breath, cough, difficulty breathing lying flat. And this has progressed over several months' time. She additionally has vague right-sided sharp chest pain, which is non-exertional, and describes being chronically tired for about 10 years and is unable to keep up with her coworkers, and she works in healthcare. She has a past medical history of depression, anxiety, fibromyalgia, and hypertension. She receives a cardiac evaluation because of her complaints, and she starts with a chest x-ray where they note pulmonary edema. Pulmonary edema can be a finding to suggest some degree of heart failure. And so this was followed by an echocardiogram. And this is a fairly typical course. The left ventricular ejection fraction should normally be about 55 to 60, and it was 25% by echo, and so diminished cardiac function. Labs were also obtained. CK-MB, which is the fraction of CK that is supposed to be specific to the cardiac muscle, was elevated. However, her troponins, which are another cardiac enzyme, were normal. A catheterization was performed. She angiographically had normal coronary arteries, meaning that she has no coronary artery disease in cholesterol plaques and the like. But she was noted to have a depressed ejection fraction also by the images obtained in the catheterization. So they made the diagnosis based on a couple of other important features in her clinical history. She has a 35-pack year smoking history, which is ongoing. She admitted to a substantial degree of alcohol intake. And so she was diagnosed with alcoholic cardiomyopathy. She was initiated on heart failure therapy. and her ejection fraction did improve. So it started out in the mid 20s and increased to 45%. So while not entirely normal, a big improvement. She had difficulty with follow up due to need to care for her chronically ill child. And so the follow up was pretty sparse after that. So in medicine, we have this axiom. We refer to it as Occam's Razor. And what that means is the explanation for any phenomenon should make as few assumptions as possible. And so the most obvious answer generally is the answer. And you don't need to be looking for really kind of obscure things. And usually the answer should be as simple as you can make it. So, cardiomyopathy, secondary to the routine kind of cardiac disease you earn. So, high cholesterols, coronary plaques. It's the most common cause of heart failure in this country. 2.5 million people in the United States have ischemic or coronary artery disease related cardiomyopathy, with an incidence of 40,000 new cases per year. So, this is a real problem. The incidence of alcoholic cardiomyopathy is 1 to 2% of heavy alcohol users, and it's estimated that about 25 to 33% of the non-ischemics, so not the ones with any coronary disease, those cardiomyopathies are attributable to alcohol. And so the conclusion that was made in this patient's case is not unreasonable. But you're not here to hear a talk about standard cardiomyopathy, and so I go back to my title slide to say there's clearly something else going on here. So, common disease is common, and rare diseases exist but are rare. And so, the question I would pose is cardiomyopathy secondary to muscular dystrophy really rare? And I think that that fundamentally is also a bit of a problem because the denominator in terms of how many women are there, and you just heard Anne talk about the different kind of more population based assays, we're going to start seeing kind of what the actual denominator is in terms of these patients. And I'm not sure that we know the answer to this. I mean, I have a couple of guesses, but not totally sure it's rare. I will tell you that there is an ascertainment bias in adult cardiology clinics where this type of cardiomyopathy isn't actually seen that often. So, muscular dystrophy centers are often centered within pediatric facilities. And that includes the boys that are affected with substantial cardiomyopathy into their 20s. And so, knowing the natural history of the disease in boys, it is generally felt to be a teenage and 20 and 30-year-old man that has myopathy, but may never actually transition to an adult facility. There's also the lack of recognition of potential impact on disease in female carriers. And so we have real ascertainment bias problems. And so we hope to answer more of these questions, but I'm not actually sure this is a rare disease. So if I add to the clinical presentation that this patient is a suspected DMD carrier, has a high CK, and her son is in his early 30s under his care, that hopefully changes the picture. And so asking the right question is really vital in terms of getting at what is the actual cardiomyopathy, and putting it into your differential in terms of your differential diagnosis is important, because if it's not there, you're going to miss it. So, in follow up, this patient was reevaluated by her cardiologist about 2 years later. She continued to have this right sided chest pain, and an echo was repeated. The left ventricle was non dilated, and so that's good. She had globally depressed LV systolic function and was maintained in the 40 to 50% range. She had a stress test done where her functional status looked good, but she did have a little bit of a defect on that study in terms of the imaging on that study. And so they actually repeated the catheterization. Not to be deterred, she again had no coronary artery disease 2 years later. And so the patient then presented the possibility of this being Duchenne disease because of her son. And she actually initiated the referral to a carrier clinic for consultation. This is a pretty typical story. And so I highlight it because I'm thinking that there are additionally people on this call who have gone through a similar experience. Not exactly this, but there are going to be tenets of this particular case presentation I think will resonate with some of the patients there, where you're really advocating for your own kind of diagnostic evaluation based on what you know. So this patient had a cardiac MRI with me at that point, and her function was in fact slightly diminished. The heart volumes were near normal, kind of upper normal, But what was pretty remarkable was that she did have fibrosis. And so when you use contrast enhancement on an MRI, you can get these linear looks. And so it's hard to tell on the slide, but there are these white areas within the myocardium, within the heart muscle, that are white and not black. And that's called hyperenhancement. And it was in a typical location that we see in the boys who have Duchenne. And so it starts in the base and it proceeds onto the mid ventricle. And it happens in that inferior lateral and lateral wall segment. And this is all consistent with carrier cardiomyopathy. Alcoholic cardiomyopathy looks quite different than this. And so, in seeing the MRI, it was fairly evident that this was the impact of her carrier status. So I was trying to put together themes for the patients that I've seen with Duchenne carrier cardiomyopathy. And there are a couple of things that kind of keep coming up. And so there are patients who are misdiagnosed. And so the most typical things I hear are that they had broken heart syndrome, attributable to the stress of caregiving in terms of their children or some other stressor in life and jobs and everything else, and COVID probably. All of these things were referred to as broken heart syndrome, which is also called stress cardiomyopathy, which is there are quite a few different names for it, and that was a fairly typical presentation. Most of these patients have had catheterizations looking for the typical type of ischemic coronary artery disease type of cardiomyopathy, and they all had clear coronaries or some other cardiomyopathy like alcoholic cardiomyopathy. And so the misdiagnosed were fairly common. Undiagnosed patients were additionally sadly common. There are lots of barriers to care. And so, access to a provider with knowledge that carrier cardiomyopathy even exists is a challenge. There are also clearly caregiver roles that a lot of these women continue to have, and it's a heavy burden. And so, the focus in these families is often on the care of their child, as it would be for any of us. And so, the undiagnosed are clearly a problem. And then the diagnosed. And so, even people who know they're carriers and know that there's a risk of this, the issue is access. And so, because of that, I really applaud this team at UPenn for really wanting to take this on, and Dr. Wang and Dr. Riza for wanting to champion this, because we really just need more clinics, lots more providers, lots more clinics, lots more people who know about this so that we don't rely on the patients to present this as a possible diagnosis. But even with that, we're all still learning, right? There's limited guidance in regards to the diagnostic criteria for what is manifesting, and then how to manage these patients are all still works in process that we hope to answer, but still difficult. So why does it really matter? So if I'm treating someone with heart failure, does it really matter what I call it? And I would say absolutely yes. And so there is truly a psychosocial impact in terms of knowing what you have and what to call it, both positive and negative. And so on one hand, when women come in, they're truly frustrated. And I get it. They've had these issues for years, their function's down and their coronaries are fine. All of the testing comes back fine. And so there is this frustration with negative testing that I think we have to acknowledge. And so on one hand, you don't want me to tell you that there's something wrong. On the other hand, you need to know what to call it. And I think that there, even though no one wants me to say to them, yes, you have carrier cardiomyopathy, on the other hand, the sense of relief these patients have can't be underplayed. It's pretty amazing. I think with that as well, is there a lead time impact for treatment? And so if I diagnose someone who's 25 with fibrosis and I start her on therapies, does that patient look different when they're 65? We don't know. But you have to think that there's some lead time impact for treatment. That if you start treatments early because you just know what you have, then it changes things. Because an ejection fraction of 55 isn't totally normal. I mean, it's considered normal or within a normal range. But if you're an otherwise healthy 30-year-old person, it would kind of raise your index of suspicion some if you're a known carrier. Is there a role for standard and non standard heart failure treatment in this population? I think these two questions are really to be determined. And I hope to answer some of these questions as our research progresses. But I'm not sure that anybody has a clear answer to this. But I think we know what direction to take it in. And I think we know we have a sense of what to try. And we're getting better and better at it as we consolidate and continue to treat these patients. So, what we could comment on is this life expectancy impact. And I know that seems like we're kind of putting the cart before the horse where you're going all the way to the end impact. But I would say that it's still important information to have kind of as women going into this unknown. So, I've told you, like, yes, it's important that I tell you what you have. I'm not totally sure 100% kind of what the guidelines for treatment are and that there's a true impact to starting you when you're early, but I can tell you what it might look like. And so, in some ways, I hope that that would give people some degree of reassurance. So, there is one study, I'm not going to say it's a good study, it's death certificate data study. And they did this in Scotland, and they looked at all the death certificates and said, oh, okay, well, the expected number of women who are carriers for Duchenne are still alive when they're 70 as compared to the general population, and when they're 75, and when they're 80. And so they looked at it, and the conclusion from the study was that there's no difference. And so the expected number of women who are alive at any given age in this study were what they expected it to be. And I find that horribly reassuring, but then I get super frustrated with it when it says this study does not suggest that there should be any sort of routine cardiac surveillance of obligate carriers, that it's unnecessary. So I think that's a stretch, and so I would stop it at the life expectancy is normal, and everybody take a good deep breath and then ignore the last sentence of the paper, because I think that that's incredibly short-sighted because we don't have answers to those second two questions. So we sought to answer some of these things, and so this is the paper that Dr. Scavino was referencing. And so it was a truly collaborative study with cardiology, neuromuscular, psychology, physical therapy, and we all kind of approached it with a "we know nothing" attitude, and let's see what we find. And so I'll go through some of our study findings with you. So what we do know. So, Duchenne and Becker have been defined genetically, as Anne very elegantly described kind of in her first slides. Some moms are genetically proven carriers. So about 70% of women are carrier moms. Some moms don't carry a gene causative of Duchenne or Becker in their sons. And so we will refer to those as non-carrier moms. And so while they are moms of boys with Duchenne, they do not actually carry a gene that can be identified that makes them a DMD carrier. So what had been known up until the point where we did our study, and has been reported for years and years and years with fair consistency, was that about anywhere between 9 and 15% of women who had a gene defect, a DMD gene defect as a carrier, had dilated cardiomyopathy. So that just says the heart muscle is bigger than you expect it to be, it's fuller. It doesn't really comment on function. There can be some reduction in function, but it was felt to be fairly rare. Something that low of a percentage kind of later in life when you're 50. They just kind of felt like it wasn't that big of a deal, and that it increased with age, but really it was a fairly low prevalence of disease. And this was all based on echocardiograms. So, in a lot of these studies, genetic confirmation wasn't performed. And so, like Anne said, 70% of women have a genetic defect, but that leaves 30% that don't. And so you've artificially inflated your denominator. So if you think all of the women that you studied were at risk, you would be wrong, and you would be decreasing kind of what you're catching in terms of your prevalence reports. There was no prior accounting for concomitant diseases, and there was no prior normalization for evidence of skeletal muscle disease, and all of the studies were small samples. We also know that most of the studies that were done previously relied heavily on echocardiograms. And so echocardiograms are great for certain things, for valve disease, for function, but they really can't assess the character of the myocardium. And so that one slide that I showed you with abnormal gadolinium enhancement, you would never see that by an echocardiogram. And so MRI really is the workhorse for this disease. But even beyond that, the definition of disease by MRI was really variable. And so there are some reports out there that there was 100% abnormalities found on MRI. It just depends on what you use for abnormal. And so if you use slightly abnormal or upper limits of normal, and all of those people are considered abnormal, then you also have a problem. And so you don't want to underreport, but you also don't want to lose your mind and report everybody as well. And so we wanted to kind of be more precise in terms of our definitions. And so we undertook this longitudinal prospective cohort study. We did not do an intervention, so we did not start anyone on treatment. We just studied them for 3 years. Like I said, it was an interdisciplinary study, and we used MRI exclusively over echo. And we added a component of a functional assessment because of the foundation of this being a neuromuscular disease. We did place all of the women on treadmills to assay what their functional status was. So we ended up with all the women were genetically tested, and we ended up with about what we expected. So there were 77 muscular dystrophy carrier moms, or MDC moms, and 22 non-carrier moms. So again, the moms who have boys with Duchenne but did not have a gene defect. And then we also recruited 25 healthy control women who happened to be hospital employees that were age matched. And they all kind of came out looking pretty similar, including in the exercise test. And so, the carriers did pretty well. And so I'm not sure these numbers will mean anything to you, but they're the same. And so when you look at carriers versus non-carriers versus our hospital employees, all of these numbers are statistically similar. And these are all measures for how much energy the aggregate of your heart, your lungs, and your skeletal muscle give you to be able to perform a treadmill test. And so they actually came out looking very good. The MRI was where they really started to diverge. And so fibrosis was seen in almost half of our carrier moms. We had one non carrier mom with fibrosis, and none of the controls had fibrosis. And so this was a fairly dramatic difference. And so, in half of the women who were genetically proven to be carriers, we saw these abnormalities by MRI, specifically fibrosis. The location and pattern of the fibrosis did mirror that of the boys, and it was in the subepicardial region, just like I showed you in that one example. So then you go back to, really, is it rare disease? And so if you just kind of do a quick sketch, and I'm obviously kind of taking some liberties with the numbers, but if you have 10,000 boys in the US under 25 years of age with a DMD mutation, and we presume 70% of them are inherited from a carrier mom, then you have to say that there are 7,000 carriers in the US. And this is clearly an underestimate. So it's not counting any of those without affected male offspring that are too young to have kids, that haven't had children. And then you take half of them, 49% of them, who are LGE positive by cardiac MRI, which means you have 3,500 women in this country with cardiomyopathy attributable to Duchenne. So I would pose to you that this isn't actually a rare disease. It should be within everybody's differential, and it makes the issues of access even that much more important. So, one of the things that we tried to do in our study was predict which carriers are at risk of fibrosis. The thing that came out the strongest was age. And as I get older, this is harder and harder to swallow, because I think this is true of all disease, it seems. And so carriers who had fibrosis were older. And so, 38 versus 44. The youngest carrier I had in the study manifesting LGE positivity was 31. There are younger carriers out there, and they're clearly manifesting young girls out there. And so this study really didn't speak to that. It was really to a somewhat normal adult female population. The interesting thing is the odds ratio was almost 11 per decade of having fibrosis. And so that means a 45-year-old would have a 1 in 2 odds of having fibrosis. And so as you age, you really have to know that there is this increased risk. Additionally, the women who had fibrosis also showed me a little bit of abnormal heartbeats towards in recovery of the treadmill test. And it was fairly predictive of those who were going to have fibrosis on the MRIs. So we put this all into a model. This wasn't in the paper. It was something I played with later just to kind of get a sense of it visually. For me, I'm very visual. And so, and I think for some of the younger carriers that weren't really spoken to necessarily in the original paper, when we had average ages of about 40, it kind of helps you get a visual in terms of what your risk is. Because when you look at the probability of having fibrosis, kind of in the y-axis here, and this is age and years coming across, you can see when you just look at age alone, which is just this blue line, you start out down here at 67% probability, and then you start going up with each decade, with each decade, and you flatten out kind of in your 40s and 50s. If you add in kind of that, what I called it recovery ectopy, it was the ectopy and recovery of exercise, and you added in a high CK, you could improve or increase your probability of it to some degree. But the biggest driver clearly of this model is age. So as a final thought, genetic testing is key. And the cardiac disease and muscular dystrophy carriers is real and it is prevalent. And so, if there's anything I want you to take home from this, is that we are clearly underestimating the number of women out there that are affected by this. Most importantly, though, there are a third of women out there that are non carriers that never need to see anybody at UPenn, anybody in Columbus, Ohio. You don't need a cardiologist short of your regular risks in regards to your coronary disease and the other stuff that we've talked about that's more typical. And so, being able to clear a third of women is a huge, I think, a huge relief. There is also no clear connection between a boy's cardiomyopathy severity and onset or the specific genetic mutation in a family that seems to predict. And so when I ran all the genetic numbers on the women with and without fibrosis, not one gene mutation came out as specifically higher risk in regards to the cardiomyopathy. And so that was also helpful. I would also note that on a positive note, the functional status of this cohort was relatively young, 30s to 60s, was still very good. As I said, they were really not that much different than the non carrier moms and the controls. I do think that the drop in ejection fraction trails fibrosis as a later finding in carrier cardiomyopathy, and that age matters. And so increasing age results in a higher risk for fibrosis, and that I generally recommend MRIs in the third decade of life, ideally with gadolinium contrast as a screening tool. The LGE, that fibrosis by MRI, is one piece. We are also looking at other pieces that might help us increase our lead time to diagnosis, because if I can diagnose you earlier, I could possibly start treatment earlier and affect the timeline in terms of kind of what the natural history of that might look like. And I think this becomes increasingly important as we get a sense of the advantage in terms of lead time treatments. So, I started with that first vignette, which was, a little bit of all of the things that go wrong. And I want to end with a better one. So, this is a 47-year-old DMD carrier who is functionally asymptomatic. She had a cardiac MRI in 2001 at the age of 29, and her ejection fraction was noted to be 30 to 35%. So, definitely not good. And they didn't know what to do. Back in 2001, they just said, that's what you have, and there's nothing to do about it. And so she had no cardiac therapies or cardiac care in the interim until she presented about 20 years later with an admission for heart failure. And so she was admitted for shortness of breath, had an ejection fraction that was not too dissimilar from the MRI that she had almost 2 decades before, with an ejection fraction of 28%. I saw her about a month after that admission, and we started heart failure therapies with up titration over the next 6 months. And a little over a year later, she had improvements in her EF again to 40 to 45% by echo. In this period of time when she was away from care, she had multiple children, did not appear to have a decline in terms of ejection fraction, and then additionally was able to respond to therapies with a substantial improvement despite not having any care for over 20 years. And I think what that says is, if you have some dystrophin, you do respond to therapies. And so you may not have a normal level of dystrophin compared to another 47-year-old woman. But I think this really gives us hope. I didn't see a 29-year-old in the study with an ejection fraction that low, but patients like this do respond to treatment. They just have to get it. So next steps for us is completion of our study in May of 2022. So thank you, COVID. Our 3-year study ended up being a 5-year study. And in some ways, I'm going to make lemonade out of that, because we get a bit of longer term follow-up in some of these women. So I can comment more in terms of what that looks like over a 4 to 5-year period of time instead of a 3-year period of time. And so we'll complete that testing in May. And so my job this summer is to analyze that longitudinal paper and hopefully get us some more information. I have to acknowledge PPMD, who funded this study and 100% has been supportive of our research program at Nationwide Children's in regards to this carrier project. And clearly without them, that would not be possible, as well as the Heart Center Research Program, who also helped with funding of the study. So with that, I will send it back to Mina.
Okay. Thank you so much, Dr. Ma. That was incredible. And for some sake of time, we'll move on, but we do have questions at the end, and I thank you for that amazing presentation. Next, I'd like to present Dr. Teresa Wang and Dr. Nosheen Reza from the Inherited Muscular Dystrophy Clinic, the Duchenne and Becker Carrier Clinic, part of the Penn Medicine Center for Inherited Cardiovascular Diseases. I'd like to really thank them for all the work that they've put into making this idea reality, and take it away. Thank you so much.
Great. Thanks, Dr. Scavina, for the wonderful introduction. Dr. Reza and I are really excited to be here today to introduce our group and this new clinic to the PPMD community. This partnership was really sort of born out of the need for clinical care for female carriers, and really hope to bridge this gap moving forward. So in the next 5 to 10 minutes, we'll talk about our goals and hopes for this clinic in the future. We'll introduce our team. We'll review what you might expect at a carrier clinic visit with us and some of the services and testing that are available. And then ultimately the logistics of how to schedule an appointment. So historically, multidisciplinary care is really focused on caring for males with muscular dystrophy, or as Dr. Ma laid out, we're finding more and more that female carriers can really present with very similar cardiac issues. But clinical care for this population in the community is pretty variable and often can be incomplete. And so we hope that creation of this clinic will allow specialized and very individualized care to hopefully improve some of the long-term and physical and emotional health of carrier patients. This will be one of the first clinics of its kind, and so we hope to pioneer a new standard of care that can hopefully be modeled for future carrier clinics across the country. We're very much committed to collaborating in education and advocacy and public health domains to increase awareness and community engagement for this population. And I think that at Penn, we're very uniquely positioned as a large academic medical center to really utilize our existing sort of research infrastructure to help advance scientific knowledge in this field. So the Duchenne and Becker Carrier Clinic is made up of specialists from across multiple health disciplines, including cardiology, pulmonology, neurology, and also social work. Our cardiology group is shown here and is made up of a whole team of physicians, nurse practitioners, nurses, genetic counselors, administrators that are really committed to helping you get individualized care. And so at your clinic visits, you'll interface with any one of our physicians, myself, Dr. Reza, Dr. Day, Dr. Owens, our nurse practitioners, Amy Marzoff and Nicole Hornsby, as we sort of screen and evaluate you for any cardiac issues. At your initial visit, you'll also meet some of our genetic counselors, Jessica, Lily, and Lacey, who will work with you to determine if any initial or repeat genetic testing is necessary. And then our support staff of nurses and administrators will really help with obtaining any cardiac studies that have already been performed, and then also help answer any questions you may have either before your initial visit or in subsequent follow-up. And Dr. Goldberg is one of our cardiologists who has specialized in seeing and screening many of the adult men with muscular dystrophy. So as a tertiary care center that has many specialties and subspecialties, we know that navigating the healthcare system can be very challenging. And so we hope to provide a very comprehensive care that starts from the time you contact us to schedule your appointment. So prior to your first visit, we'll work with your insurance as necessary to get any authorizations to get you seen here at Penn. And if you've already had cardiac testing, whether it be an EKG or an echo, or I saw some people had cardiac MRIs, then we'll work with you to gather that testing, including the result reports, as well as the images on CDs in advance of your visit, so it doesn't have to be repeated here. And then at your first visit, you'll see either the physicians or the nurse practitioners, and we'll take a comprehensive history, perform a physical exam, we'll review any prior imaging that you've had. If nothing's been performed yet or is incomplete, then we'll go ahead and try our best to schedule it the same day as your clinic visit. And then our genetic counselors, as I said earlier, will meet with you. And then we'll also go through some sleep and well-being assessments and screenings to determine if there's any further need for referrals to either sleep medicine, pulmonology, neurology, social work, or other ancillary services. And then after your visit, we'll review any studies that you had done, which will help us determine sort of the frequency of ongoing follow-up moving forward. Here's some of the cardiac testing that you may receive either prior to, during, or following your visit. And some of this testing may be dependent on your insurance, but certainly includes an EKG, an echocardiogram or an ultrasound of your heart, a Holter monitor, which is essentially a small wearable device that measures your heart rhythm continuously and tells us if there are any abnormal rhythms going on. A cardiac MRI, as Dr. Ma had talked about, which really sort of gets at the characterization of the heart muscle. And then blood tests looking at your heart and skeletal muscle, and then a specialized stress test called a cardiopulmonary exercise test, which measures how well your body transports and uses oxygen. And so with that, we look forward to working with you in your medical care. Here's the phone number that you guys can call to inquire about an appointment in the Duchenne and Becker Carrier Clinic here at Penn. We are located in the Perelman Center for Advanced Medicine, which is in University City of Philadelphia. Thank you.
Thank you so much. Can you all hear me?
Yes.
Okay, thank you so much, Teresa. That was wonderful. And again, I really like to thank everyone at the Penn team for the work that you've put into this project. We started this discussion in September of 21, and 6 or 7 months later, we are here. So that speaks to everyone's enthusiasm and excitement moving forward. We have a number of questions that have come into the chat. I know for the sake of time, I will go through some of them. This webinar will also be posted on the PPMD website in probably about a week, and there will also be a follow-up blog by which to also ask questions, and Anne and Nikki's website has been, or email address has been included for specific genetic questions which you may have. So I would like to bring up some of the questions, particularly as they pertain to the cardiomyopathy. And one of those questions, which I was just actually asked yesterday in clinic, was at what age should a carrier have a cardiac MRI? And perhaps from the cardiologist, Dr. Ma, if you'd like to start, and Dr. Wang and Reza, if you have thoughts on that, that would be really great.
So that requires a longer conversation with the family. I think that some people like to know and some people don't like to know. I think the latest I would do it is in your 30s. Depending on any sort of skeletal muscle manifestations, because I do think that there is a population of young girls who phenotypically or who clinically look much more like an affected boy, that you could certainly make an argument for doing it much earlier. And so I think it's case by case. But if you're an asymptomatic person who is doing just fine, I would say no later than your 30s.
And I'd agree with that. I think that matches with the guidelines that come from the AHA and the ACC. And so in 2017, they have just one line on carrier testing, and it's what we call a class 1 recommendation, but that all female carriers should undergo cardiac evaluation by exam, EKG, and some sort of non-invasive imaging, whether it be, I think, at the time they wrote this, probably echo, but nowadays maybe cardiac MRI in the second or third decade of their life.
Great, thank you. Another question similarly is there an increased risk for carriers as to whether they are carriers for Becker or Duchenne muscular dystrophy? So I suspect if their son has Becker or Duchenne muscular dystrophy. Dr. Ma and Dr. Reza, Dr. Wang, if you'd like to take that on, or
Um, Sure. So I looked at that, and there really wasn't. Although I will tell you that the representation in terms of our study was fairly low. I believe I only had 7 women with Becker's. I could go back and look and make sure, but it was about 10% of my sample, and I didn't see a difference. I will also say that that is also true with the boys. The heterogeneity of Becker's is really wide. And so, you'll have men who walk into your clinic in their 60s using a cane, and then you will have severely affected boys in their teens requiring a heart transplant. So I think that given that heterogeneity, my tact has been to be more conservative. And in that way, I would say I would treat you like you're the most severe Duchenne until you prove you're not. And so, and maybe, and that's probably my practice bias in having seen the boys. And so, if Dr. Wang or Dr. Risa have a different idea about that, I'd be happy to hear it.
I think I agree with you, Dr. Mai. I think that there have been some studies that have shown sometimes a higher prevalence of either fibrosis or cardiac dysfunction in Duchenne carriers compared to Becker carriers, but there honestly is not enough data out. And a lot of the one study that I'm looking at in terms of prevalence is a pretty small study, and it's only one study. So I think I would treat you all the same until, like Dr. Ma said, until you prove otherwise.
great, thank you very much. In terms of younger women, we are getting some questions about that. And I do think that it would be valuable as we have all this additional genetic testing coming forward and identifying younger carriers to have a dedicated webinar for that. I think there are many questions surrounding steroid use, prognosis. We don't have very good natural history data, but that information is also being currently evaluated. So I think some of those questions will be answered. I don't know that we have answers for all of those things yet, but I will say that if in the pediatric world or someone presents to our clinic, say 17, 16 years of age, and is already symptomatic, a cardiac MRI, I suspect, would be in order. And then do we have guidelines, or would you utilize guidelines similar to what you would use for either young men with Duchenne or Becker, or for other entities that have heart failure and cardiomyopathy? So Dr. Ma or Dr. Reza or Wang, what are your thoughts about that for the younger carriers in terms of treatment options and medications?
Yeah, I mean, I think that's a tough question to answer, mainly because there just really isn't any data out there in terms of younger patients. And so I think to a certain extent, we can extrapolate what we know about carriers, older carriers, to the younger carriers, but in a different sense, you're almost extrapolating what you know about the boys with muscular dystrophy to the carriers. That's a convoluted way of saying I think we really don't have exact guidelines. And I think that's part of the reason that we wanted to stand up and create this clinic, is so that we have more information to go by, and to hopefully create these standards of care in the future.
Great. Yeah, I mean, I think in asking such, I really wanted to bring about the fact that there's a lot we don't know, and really the reason and the inspiration for this type of clinic and what we hope to accomplish. And not only from the cardiac, from steroid use, from prognosis, and from so many other things that I think really just haven't been looked at to the degree that we can give very good answers. So we're here to think about these questions and try to answer them. We encourage you to reach out for an appointment if you feel that this is a place where you would feel comfortable and would like to be seen, PPMD, hopefully we will wrap our arms around having other set webinars to bring up topics of interest. So I really thank everyone for being here and all the work that you've put into this. And thank you really all for your time and a really great webinar. Thank you so much.